Coronavirus, a worldwide pandemic.
Millions affected across Northern California, the country, and around the world.
It is every time we win, we celebrate it.
Healthcare systems stretched to capacity.
We still have supplies, but they're being restricted, and so we're not able to get access to them the way that we feel is appropriate.
With more people getting sick every day.
Tonight, the resources to protect each other and ourselves, what you should know and what to expect.
This is a KCRA 3 News Special, Coronavirus, the State of Care.
Good evening, I'm Edie Lambert.
And I'm Brian Heap, and Edie and I are trying to maintain our social distancing about 6 feet apart. There we go. So tonight we are going to be talking with the people in charge of the 4 major healthcare providers in our area. We're going to ask them what they're doing to ensure everyone's safety during the coronavirus outbreak.
As you know, the outbreak, one way or another, affects everyone around the world, across our country, and right here in Northern California. There are more than 1 million cases now worldwide. Nationwide, more than 12,000 people have died and 387,000 people have tested positive for the virus.
Here in California, more than 16,000 people have tested positive and nearly 400 people have died. All of this has put a strain on the resources we have across the United States, and eventually we are expecting to see the same strain here in Northern California.
For the past few days, we've been asking you, our KCRA 3 viewers, to send in your questions. Many of you have asked what hospitals are doing to prepare for a potential surge in patients and whether there's enough personal protective equipment. And we still want to hear your questions. You can email those to us right now at news@kcra.com. And we'll get to as many as we can in this hour.
But before we start asking those questions, we want to introduce you to the healthcare leaders that we have with us tonight. And starting with the top left of your screen is Lori Harding. She's the CEO of Dignity Health for the Greater Sacramento Division. She spent more than 30 years in healthcare leadership, and half of that with Dignity Health. And then to the top right is David Cheney, the CEO at Sutter Medical Center in Sacramento. He's spent more than 30 years in healthcare and began his career as a paramedic.
Trish Rodriguez is the Senior Vice President and Area Manager of Kaiser Permanente South Sacramento. She oversees integrated health plan and hospital operations. And Dr. David Lubarsky is the CEO of UC Davis Health. He oversees UC Davis's health, academic, research, and clinical programs. So thank you all for joining us tonight. And the first question we have is really how you all work together. We want to ask all of you this. So Lori, let's start with you.
Thank you. Great question. You know, fortunately, the 4 health systems, as leaders, we get together almost on a quarterly basis, and we talk about things that are affecting all of us. Homelessness is a great example, and we just try to collaborate, and we combine our resources together where we can have a bigger impact on the community. So we have a very good collaborative relationship together.
Trish Rodriguez with Kaiser, how are you working together specifically with this particular concern with coronavirus?
Sure. Thanks for that question. You know, we're also concerned not only with the preparedness at our medical centers, but also how this is affecting the community. All of the 4 major health systems are working with Sacramento Covered on providing meals for the homeless, and we have to think about that. We not only have to think about the 4 walls of our medical centers, but how it's affecting the community, and it's been a great collaborative effort.
David Cheney with Sutter, I know there are also concerns if one hospital ends up with too many patients, that overflow may go to a different system even.
Yeah, thanks, Edie. So the beauty of having a integrated network like Sutter is that we can move those resources around as needed. So if one of our small community hospitals does not have the PPE or the ventilators, then we could move that equipment or human resources around as needed.
And Dr. Lubarsky, I ask you the same question at UC Davis Health.
Right. Well, So I'm actually on a advisory committee that has been put together by the California Hospital Association, the California Medical Association, with participation from the Governor's Office of Emergency Services and the physician leadership from all four organizations get together at least once a week to talk specifically about how we might deal with the surge, what is the latest evidence in terms of the number of patients that are affecting us and where we are currently, and what we're suggesting for both PPE, protective gear utilization, and anything else that might be coming out. And that's been going on for about a month now already, and we are all prepared and preparing similarly to make sure that the Sacramento region is both well-served and well-prepared.
Another question for all of you. We have all heard about the shortages that are happening with PPEs, the personal protection equipment all across the country right now, and a lot of concerns right now about whether our healthcare workers are being protected while they're doing their work at each of your hospitals. So let's just go around again, and let's start with you, Mr. Cheney, and you tell us what's happening at Sutter with regard to that.
So this is an ongoing issue for us, Brian. Just making sure that we have enough PPE for our staff. It's critical that we keep our staff safe, and we will not relent on that at all. But it's a day-to-day thing, just trying to search down new vendors for the PPE. We've scanned the globe, trying to find both masks and gowns and shields. And I can tell you right now we're comfortable, but we don't know exactly when this surge is going to come. But we're confident that we will have the equipment that is needed to make sure and protect our employees.
And Trish Rodriguez with Kaiser, let's give it to you as well for the same question.
Well, thank you. And what I want to say is that safety is the first priority, and the safety of our staff, meaning that we provide them with medical grade PPE to take care of our patients based on science. So we're following CDC guidelines to ensure that our staff are safe.
And let's take that question as well to Lori Harding with Dignity. So tell us about the personal protective equipment and the concerns for your health workers.
Sure. So we've been following the CDC guidelines as well, and as you know, that's been changing almost on a daily basis, so we're tracking that very closely. We recently went into what's called universal masking, requiring that everybody in the hospital setting wear a surgical mask so that it's protecting not only the staff from the patients, but also patients from potentially staff who are asymptomatic. So the PPE issue is huge for all of us in healthcare, and that is where I spend probably a good 50% of my time. Just like David said earlier, we are looking globally at different vendors to be able to provide some of this PPE. China is finally starting to come back in being able to provide and send PPE over here. Some of the other countries as well, but as you know, this is a worldwide pandemic, so everybody is faced with these challenges. Today, just like the others, we're comfortable. We have enough PPE for our employees and for our physicians. But should the surge hit, we are right now working on getting that access to the additional PPE so that we can take care of everybody during this surge. But it is a big challenge for all of us.
And Dr. Lebarsky, what are you doing over at UC Davis Health to help to make sure that your workers have the equipment they need?
Right. Well, we're very confident that our workers will. There is nothing more important than the health and the well-being of the staff who are serving our patients. That is, we can't do good medical care if if we aren't doing a good job taking care of the people who are taking care of the patients. We have more than enough PPE right now, and enough PPE to last us into the surge, we believe. We are using the PPE according to appropriate CDC and World Health Organization guidelines. You do hear occasional complaints like we can't get enough PPE, but I think it's important to address that head on. What people want may not be warranted by the science. And we are actually all trying to follow exactly how this disease is transmitted and make sure that the personal protective gear that's appropriate for that patient in that setting is what's worn and what should be worn. Because that's the only way that we will have enough for everyone who needs it, when they need it, when the numbers increase.
So to that exact point, we got a very specific question for Trish from an ICU nurse from Kaiser who wanted to ask why Kaiser is not following the most recent CDC guidelines and refusing to supply nurses with N95 masks. So I quote directly there from her question.
Well, thank you. That's an important question. We've been thinking about PPE, as Lori said, almost every day, following the science, following the guidelines. And N95 masks are certainly warranted in certain situations, and our staff have access to those N95 masks for the situations where they're required throughout the medical center. Because they are. In certain situations, we want to include those and other types of PPEs. So they have the access to those masks.
And Trish, there's actually a follow-up on that same topic for you at Kaiser. It says, how does Kaiser plan on taking care of their nurses that become sick with COVID-19 as a result of using the Kaiser Permanente issued surgical masks?
Well, the use of masks, the appropriate use of PPE will prevent any of our healthcare workers from becoming sick. And if they do become sick, whether it's community acquired or hospital acquired, we have monitoring programs, working closely with employee health, ensuring the safety of our nurses and care in their home if they should need it. So again, safety and the protection of our employees is our first priority.
We should mention that we just heard a major hotel chain offering up hotel rooms for frontline healthcare workers, which is great if they need just a break or if they need to be in isolation, which is a really nice contribution there. Dr. Lebarsky, what are you doing for your employees who contract coronavirus?
Well, it's the same thing. We have now, because of our some expanded testing capacity, even for people who have mild to moderate symptoms, we're doing testing for all of our employees and staff and making sure, first and foremost, they know in all instances if they actually have COVID-19. Currently, and this has been fairly constant, only about 1 out of 20 people who come in with symptoms suggested of COVID-19 actually have that. The other 19 out of 20 usually just have the flu. So number one, we're setting the vast majority of people's minds at ease about the type of disease they have. And of course, if they are ill, we're providing all the health care that they need, including video visit support and anything else that might be appropriate to allow them to recuperate at home. And God forbid they need to come to the hospital, the finest care that we possibly can.
David Cheney, what is Sutter Health doing for employees who get coronavirus?
Yeah, thanks, Edie. Very, very similar to what Dr. Lebarsky just said. The key is testing and making sure that any of our employees that are symptomatic get tested. They could certainly have acquired that through the community, but we make the assumption that they acquired it in the hospital. And going through the exact same things that Dr. Lebarsky just said, we make sure that they're getting all the right care that we can possibly give them, whether that be at home or in the hospital.
So that's an important distinction, I think. Lori Harding, do you make that same determination at Dignity Health that if one of your employees gets coronavirus right now in this environment, that you assume it came from their work?
It depends on the circumstances, obviously. If they've been working around a patient with positive COVID, obviously we will assume that that's where they contracted the disease. If not, however, we have employees who travel, and sometimes in that travel, they unfortunately were exposed as well. So depending on the circumstances, but the main thing is, just like everybody has already said, we take care of our employees. We want to make sure that they get the appropriate care, whether that be through virtual care, through physician visits, but we monitor very closely, and when they're well, we welcome them back. So fortunately for us at Dignity Health, we've had very few employees who have experienced the transmission of COVID through work, so we watch this very closely.
So we had another question here. This one comes from an ICU nurse, Edie, and it's really not directed to any one of you, so I'll have you all answer it. Why are the nurses not getting hazard pay? So Dr. Lubarsky, let's just start with you on that one. Any thoughts about that?
Well, to be honest with you, if you're an ICU nurse taking care of a COVID-19 patient, there is definitely an increased risk in the environment. The idea of hazard pay has been broached in several discussions around the nation. I don't know that anybody is actually doing that. And the problem is, is of course the distinction. We deal with infectious diseases of many different types on many different levels, and deciding when one does or doesn't rise to an exceptional level is often not an easy decision to make. On the other hand, I totally and absolutely understand the ICU nurse's suggestion, and it's something that we should all think about and think about carefully, actually, because being on the front lines and taking a much greater risk, and healthcare workers on the front lines do take a much greater risk of contracting this disease, deserves at least some consideration.
Have any of you others, have you had discussions with your staff about something along those lines of a form of hazard pay in some way or another? Trish?
Well, go ahead, Lori.
Go ahead, Lori.
I was just going to say, when I went into nursing many, many years ago, one of the things that I knew when I went into this field was that I would be educated and trained to take care of patients with infectious diseases. And that's why we go through all that education to understand how to put the equipment on and take the equipment off properly. It's a part of who we are as healthcare providers. So in these times of pandemic, of course, it's much more exaggerated and much more important to understand those concepts and understand that training. But that's who we are as healthcare providers. I'm so proud of our nurses and our doctors who come into work every day knowing the challenges that they're faced with, knowing that they can make a difference in these lives that are being affected by coronavirus, and they're just doing a magnificent job. And so I just have to applaud them for that. And hazard pay is a separate issue that we haven't discussed within Dignity Health, but we are trying to do everything we can to support and protect and lift up our staff who are just coming to the forefront of this terrible pandemic.
Okay, and Trish, just you had some thoughts on that, so if you want to go ahead and just jump in there for Kaiser Permanente.
Sure. Well, first of all, just want to send out thanks and gratitude for all of our nurses, our physicians, our respiratory therapists. I'm leaving a whole bunch of people out, but they are our warriors on the front line, and we acknowledge that. And that's why our focus is providing them with the right resources at the right time. And our nurses and other clinicians are especially prepared. As an Ebola treatment center certified by the CDC, we have advanced preparation and preparedness for infectious disease. And that goes along with giving them the resources that they need, including additional training and support. So very proud of our team for how they're managing this.
Okay, and David, did you have some thoughts on Sutter as we wrap up that topic and move on to the next one?
Yeah, similar that everyone else has said. We've had discussions about it, but really our priority right now is just making sure that we have all the right equipment, the right environment to keep our nurses, our doctors, and frankly, everybody in the hospital as safe as can possibly be.
All right, thank you all. We are going to take a quick break, and next we're going to look at what happens when we do see a surge in this area, and also critically, the models are all over the map between middle of April to late May, so we're going to find out when they expect a surge and what they're planning for when that happens. We'll be right back.
We are back with our KCRA3 special, The State of Care. We're speaking with the leaders of our major healthcare systems in the region about how they're handling our coronavirus crisis.
And we want to talk about the surge that we keep hearing about, and the dates keep changing as we're practicing social distancing, and we're kind of pushing that back. So I'd love to hear what you're expecting and how you're preparing for that. So Dr. Lebarsky, let's start with you. When are you expecting to see this surge? What do you think it'll look like? And I know from talking to your communications team, you have almost like a command center set up with a lot of different kinds of logistics.
We do, and we not only have an amazing group of operational experts preparing and planning for the surge, we also have our chair of public health, Brad Pollack, who's a modeling expert who is evaluating all the models that exist out there and trying to sort through which ones are actually going to apply the most. I will just say this, that the models that people talk about for the United States really don't apply per se to Sacramento, or even the one for California, because we really have three different epidemics, one in the Bay Area, one in the LA area, and one here in Sacramento. And we're actually incredibly fortunate and fortunate is maybe not the word, hardworking, because we all went into shelter in place at a very early stage that has really flattened the curve. And I don't anticipate us reaching the peak of the disease until end of April, mid-May. And the reason for that is that it just is taking a very long time to gain traction here. And this is a great thing. It means we need to double down on our efforts, because with more time, we will have more treatments, and we will have more options, and we will save more people. So everything we're doing right now is exactly the right thing, which is putting out that surge date quite a bit for Sacramento.
David Cheney, when is Sutter Health planning for that surge, and what do your plans look like?
Yeah, Edie, so we have a command center that operates 24/7, and we're watching not only the Sacramento market, but we also watch the Bay market, because we believe that the surge might be seen over in the Bay before it comes to the Valley. So, you know, like Dr. Lebarski said, there's a delay. We actually thought a couple weeks ago that the surge was going to be happening this week, and then it got delayed for a couple of weeks. I haven't seen any models, Edie, that say that that we're not going to have a surge. The question is how big is the surge going to be, and when is it going to come? But there will be a surge.
And what do your overall plans look like for when that surge happens? How many beds, for instance? What can our community expect to see from Sutter Health?
So we've done a really nice job. We've had a couple weeks to prepare for this. So most of it's going to be in the ICU. So we've developed surge plans in all of our small hospitals, but really in the large hospitals across Sutter. We've developed and put all of the resources in place to handle a very large volume of ICU patients, and again, help out and move resources to where they're needed. So if the Bay becomes inundated, we can move resources there, or vice versa. If the Valley needs those resources, then we can move resources from the Bay to the Valley.
Laurie Harding, what do your models show at Dignity Health, and what does your plan look like?
Sure. Well, first of all, I want to start off by just saying that we have been experiencing wonderful leadership, both at the state level and at the local level. Our governor took this on strong at the beginning and ordered for the isolation, the shelter in place early on. So I think that's why California looks different from other states in the nation. Now, we do have hot spots. And we are looking at that data on a regular basis. So just like the others have said, we have local hospital. We have 6 hospitals in Sacramento. Each hospital has a command center, and then we formed a divisional command center as well, and that's looking at the data as a whole. So our data, using 2 different models. We're looking at the model that California State is using, and then we're looking at the SG2 model, which is more specific to our facilities. We're saying probably the 1st to 2nd week of May is when the surge will hit. But the good news is the curve, so the amount of surge is definitely looking like it's coming down. Doesn't mean to take a sigh of relief and relax, because as long as we keep doing what we're doing, that curve will remain flat, but it will still have a surge coming. It just won't be as bad as what we first predicted, so it's good news for us.
That is great news. Trish Rodriguez, the same question for Kaiser Permanente, and it sounds like overall through the region and through these 4 health systems, you feel like you're ready.
We're prepared. And that's in part, or a large part, into our robust planning efforts. And we're fortunate. We have command centers and work groups at both the national, the state, and the local levels, working at the medical center level, but also looking across our company to say, how will we be prepared? How should we be prepared? And so those planning efforts in an integrated fashion have helped us to be ready. And as far as models, well, we can look at our own data across all of our medical centers to look at hotspots, to look at utilization, as well as other planning models, and this has helped us to determine our approach. And so I want to emphasize, as well as what Lori said, is that the early actions of California and our elected officials, both locally here in Sacramento, as well as at the state level, has helped us flatten that curve. So we're appreciative of that, and we're really appreciative of the Sacramento citizens, as well as the 7-county region, for staying home and helping us flatten that curve.
Our next question comes to us from a nurse who wanted to remain anonymous, and it's a very specific question. The nurse said there's also the issue that if a nurse gets the COVID, the administration takes a stance that they got it in the community, despite which unit the nurse works in. So if they're in the ER and exposed every day and get sick, they have to use their own sick time, and if they run out, they have to use their vacation time. So it's obviously a very specific question, but I'll put it to you all this way. Tell me a little bit about your policy with regard to this, and number one, how do you make sure where your nurse or your medical professional got the virus, and then also what are you doing to make sure that they are protected from a pay perspective? David, Dr. David?
Yeah, hi. So thank you for that question. Well, first of all, I want to reassure everyone, it doesn't matter where or how someone acquired the disease. We're there to support that individual as a valued employee and a valued healthcare worker in our organization, and we'll do everything possible to help them both get well and to deal with this. As most people know, there are many additional time off a lot more time off being granted to deal with COVID-19 from a variety of Family and Medical Leave Act additions to additional administrative time that have been granted in some organizations, including our own. As regards to where somebody acquired it, we do not make a determination on that per se. What we do, though, is every single positive reported case is carefully traced throughout the course of the day, meaning did that worker come into contact with someone? If they did, were they properly equipped with PPE? Could we have done anything more to either educate or make the right resources available that might have prevented a transmission? And we don't make a predetermination about whether someone did or did not acquire it at the workplace. And our determination really is done by the Infection Prevention Group, which is tirelessly working to make sure that not only if this person was exposed, were there other people potentially exposed in that episode. So we are doing a tremendous amount of work to protect not only the employee who got sick, but also to make sure that any other employee who might be at risk or any other patient who might be at risk is carefully observed and informed about that risk.
So, David Cheney, same question to you. I'd like to know your perspective on this, but also specific to that viewer's question about the use of vacation time or sick time. If one of the nurses, for example, at a Sutter hospital were to come down with COVID, would he or she then have to use their own personal time in order to be able to recover from this? How does that work?
So there's lots of different mechanisms, Brian, for if one of our employees does become ill. So certainly they have a bank of hours that they can use that they are given for sick time. They can certainly use that. And like Dr. Lebarski said, while it doesn't really matter whether they pick this up in the community or in the hospital, we're going to make sure that they're taken care of. At Sutter, we presume that they picked it up in the workplace, and we're going to take care of them regardless.
And Trish, let's ask you, how's Kaiser handling this situation with its nurses?
Well, again, the safety and wellness of our team members is the utmost important, and they are on the front line. And so, like my colleague at UC Davis, we do tracers to ensure that we're looking at that employee as well as other colleagues or other patients. But there's a number of pay mechanisms that we can ensure that employee is taken care of. Also, they're followed by employee health quite closely, as well as our infectious disease experts, to ensure that, again, both their physical wellness is taken care of, and we're going to take care of them from a pay status as well.
Lori from Dignity, I guess one of the things this anonymous nurse is asking essentially is the fairness question there. Is it really fair that these nurses, when they get this COVID-19, for example, that they would have to use their own sick or vacation time to be able to recover, because this is such an unusual circumstance?
Yeah, if it is found that this is work-related, clearly they would not have to use their vacation time to be paid for that. That would come under workers' comp, and we would ensure that they get all the medical leave pay that they are deserved. So we don't try to make them use their vacation time when this is a work-related incident. So just like my colleagues.
Dr. Lebarsky, the next question really is just for UC Davis Health, because you're in a different situation being with an academic background and all of the research behind UC Davis Health. So let's talk about some of the treatments that you're developing, the clinical trials that are going on right now. And I know you're also, with many others, looking for a vaccine. So quickly bring us up to date on the science going on right now at UC Davis Health.
Right. Well, it's the reason I'm in academic medicine and have been a professor for more than a quarter of a century, is that this is the part that's just, to me, incredibly exciting, to be part of a cutting-edge organization. We have one of the NIH trials on remdesivir. That is a drug that's been tried in other coronaviruses and seemed to have efficacy. Its efficacy against this particular coronavirus was actually discovered at UC Davis's vet school, and that has led to its early use and compassionate use, and now in a large NIH trial that should be done by the end of the month. It is very promising, in my opinion. Of course, I don't know, because it's a blinded trial, but it is a very promising drug because of its past history with other coronavirus species, and the fact that the mechanism of action is well understood. It prevents the virus from duplicating itself inside your body. We're also involved with another drug that prevents the overwhelming immune response, and have already enrolled patients in that trial as well. It's in what's called an IL-6 inhibitor. That means nothing to anybody in the audience, of course, but it is the substance in your body that causes the overwhelming inflammation in the lungs that leads to the very difficult to treat pneumonia, the need for ICU, and the need for ventilators. And again, the drug's mechanism is very well understood. It makes sense based on what we know is going on inside of the lung from a very basic level of science. And again, very hopeful that that or one or other drug similar to it will prove to be effective. Last but not least, we are working with our animal labs on the main campus and our veterinary school very closely in partnership with Johns Hopkins on a way to produce a vaccine very quickly. Again, very exciting options. And last but not least, post-convalescent plasma, which contains antibodies in it from people who have previously been sick, and that seems to hold some promise in terms of being able to treat people by transfusing that plasma. So a lot of things to be positive about, a lot of things to be hopeful about, and a lot of things to say it's worth flattening the curve about, because those potential cures are coming our way.
The longer we can not get sick, the better chance that these treatments will be online, and then hopefully sooner than later a vaccine. Thanks to all the researchers, by the way, who are making all that happen.
Let's talk a little bit about testing now, because I think in the beginning it was a little bit of a slow rollout as far as testing goes, but we've definitely picked up the pace when it comes to that. So tell us all a little bit about the testing that your individual health systems are offering. How many days does it take to get the results, and how do you see this continuing to improve? And let's go ahead and start with you, Lori.
Sure. Yes, you're right. We had a slow rollout. Unfortunately, because it took 4 to 7 days to get the results back on our patients, many of our patients were sitting in the hospital waiting for those results. We had to treat them as if they're positive, so that means all of our staff had to wear the PPE every time they went in and out of that room. So you can imagine the use of PPE while we're waiting for test results to come back. We're now at a position within Dignity Health. We were able here to bring in this new fast a 15-minute turnaround time system through Abbott. We have 10 of those machines now distributed through our 6 hospitals, and it has already made a huge difference. So, for example, up at Sierra Nevada, we had 6 patients come in last night that had symptoms. We were able to test them. All of them came back negative, so they did not require admission, did not require staff to use the PPE. So immediately we're seeing the results of more rapid testing. The problem is, though, not in the machines, it's in the kits and the ability to get enough of those reagents to turn that around. And that's a national problem that all of my colleagues are experiencing. So we may have the machines, but we're not getting the kits in enough to be able to test all of our patients. So we have to be very selective. And we're being very selective on our inpatients, on our staff, our physicians who are exposed, we get them tested right away as well. And then on discharge, many of our patients being discharged, they're not able to go into skilled nursing facilities unless they have a negative COVID test. Right. So we're prioritizing those patients as well. So testing is a very important component to this entire piece.
And let's go to David Cheney with the Sutter, and you tell us the same thing. How is Sutter handling this with regard to testing? How many are you doing every day, and how long is the turnaround?
So Lori really told the story, and it's very similar at Sutter Health. We started out very, very slow with turnaround times of up to 7, 8 plus days, but it has gotten much, much better. And at this point, today we're down to 1 to 2 days, and in some cases less than 6 or 7 hours. So it's gotten a lot better. But as Lori said, it's not about the equipment as it is the swabs to collect the tissue and also the reagents. But that's getting better on a day-to-day basis too. So hopefully here we're going to be caught up over the last couple of weeks. There's quite an inventory that we have to go through, but we're hoping in the next week before the surge comes that we'll be able to have those turnaround times down to something very reasonable.
And Trish, same question for you. How's the testing going, Trish Rodriguez at Kaiser?
Well, like my colleagues, the early days, the testing was often long, but now we're very fortunate that our own Kaiser Permanente clinical laboratories do our testing in-house, and that's helped us achieve turnaround times that are much quicker, often 12 to 24 hours and even sooner. So that helps, that rapid diagnosis really helps us on many fronts. And we're also exploring other modalities like my colleagues, but having that in-house ability has really optimized the care we can give.
All right, thank you for an update on testing, and we have many more questions for our local healthcare leaders, including how people with insurance will manage medical bills that can add up to thousands of dollars if someone's in an ICU. We'll be right back.
We're back with our KCRA3 special. We're answering your questions with the leaders of the 4 largest healthcare providers here in our area. And our next question is from Emilio Garcia.
Thank you for taking my question. And my question is, have you started testing for COVID-19 antibodies yet? And if you have not started, when will you start? And I mean the antibodies, not the PCR test for the live virus. Thank you very much.
Okay, great question. I guess, Dr. Lebarsky, we should probably start with you, and let's talk about the research that's underway, and there's a couple different ways that antibodies can be used here.
Right. Well, so one is for treatment. As we said, you can find people who have already had COVID-19, get some serum from their blood and transfuse that serum and have those antibodies attack the virus before your body has actually had time to produce them. So you're using them because they don't appear right away when you're sick. But the other thing is that if you know that you've had the disease and that you've recovered, and maybe it was a mild disease and you didn't realize it and you didn't get tested, but you do show antibodies, that says you're probably not going to get infected with the disease again. So that will allow a certain amount of reduced restrictions for those people who want to go out in the community. In terms of when will the test be available, we are in the process of validating our serology test to measure that. We're hopeful that we'll have that within 2 weeks and be able to start testing people. And also in the meantime, though we didn't mention it, we also have markedly ramped up the ability to do our virus testing. We're currently able to run about 400 tests a day now, and which is enough for our organization and for some partner organizations, so that people can get turnarounds in the order of about 3 hours. And we're hoping in partnership, the state is going to work with us to become a regional resource, and we're hoping to add capacity to about 1,000 tests a day within a couple of weeks, and work with our partners right here on the screen who might want to make use of that increased capacity once we have it online.
All right, Dr. Lebarsky, thank you. So we're not quite there yet with the antibody testing, but it is imminent, so that's good news.
So let's shift gears for a second. Let's talk a little bit about insurance, costs, and billing. The Trump administration has already said, Edie, that people who do not have insurance, the hospitals will be reimbursed for the treatment of them. But what about people who do have insurance? And a lot of us are on these higher deductible plans now, so sometimes we pay 20% of an ICU visit after meeting our deductible. Are there any plans in place right now to try to help those folks out in terms of making sure they can get on payment plans, or even maybe there's some government assistance in some way or another that you all are aware of? Let's start with you, David Cheney with Sutter Health.
So this is a really important issue that we've been talking at Sutter Health about. We have not come up with a solution as to date, but it's something that we're going to have to look at because the costs in an ICU, especially if these patients are in there for 30 to 40 days, could be quite large.
Yeah, and Lori, I think to that point, very large, some substantial bills, and we could be looking at a lot of people who just simply don't have that kind of money, and we could have a lot of people with those types of bills in a very small amount of time, something that we just never have seen before.
I think the government has been pretty clear that they are trying to make as many changes to the rules so that people are not going to have to pay so substantially for this disease should they get it. So we are following that very closely. In addition to that, we have a very aggressive charity care program, so people could enroll into that program if they don't have the funds to pay for it. We will work with them to get that written off. So I think overall we're all trying to be very compassionate and understanding that this is a terrible pandemic that's taking people out of the workplace, so people's income, the revenue streams are lower, and they're lower for hospitals too, I have to say, because we're not doing the surgery procedures, et cetera, that we're used to doing. So we're all being hit very hard financially by this. But the nice thing is that the government is willing to put money behind that and to support people so that they are not having to dig into their savings accounts.
And Trish Rodriguez, I know Kaiser is structured a little bit differently maybe than some of the other hospital groups. So how does this affect you?
Sure. Well, it's a very uncertain time, and we certainly do not want our members to face barriers to care. And to that point, Kaiser Permanente has waived all copays for testing and treatment of COVID-19 for our members. Very proud of that fact. And again, we want our members to receive the safest and highest quality of care that's delivered in our integrated system.
Okay, our next question, it really speaks to people who don't have coronavirus and are now terrified to go into the hospital for any other reason. And this one comes from Samantha. She says she's 34 weeks pregnant, due to deliver at Sutter, Sacramento sometime in May. How is Sutter protecting its labor and delivery unit? But I think this speaks to the larger question of how are you protecting non-COVID patients from the people who do have the virus. So Dr. Lebarsky, let's start with you. What's going on at UC Davis Health to separate those patients?
Right. Well, first of all, I think it's really important to clarify some of the science. The virus is really not circulating in the air. You really have to be within 6 feet of somebody or have them deposit their secretions, their spit on a hard surface that you then touch and put to your face. So number one is just by walking in the hospital, that's not going to be a problem. The question is, though, just on the side of safety, at least at UC Davis Hospital, we've put all the COVID-19 inpatients on a single ward. We've turned it into a negative pressure unit, which means that air only comes in and doesn't go out to the rest of the hospital. And before that air is vented, it's scrubbed in a very fine filter that removes all the impurities, including any potential virus particles. So there is no mixture of air, but just to be for the record, it's not even necessary. That's just an extra layer that we've put in place for that.
Okay.
And by keeping the patients in one place, we think managing to make sure that every other place in the hospital is safe. We, again, 95 to 99% of the hospital is filled with just regular patients.
Okay, and this question did originally come in for Sutter, so David Cheney, let's check with you. And we're a little short on time now, so if you can keep your answer short of what you're doing to protect non-COVID patients.
Thanks, Edie. I'll talk fast. So we've done a couple things. One, similar to UC Davis, we cohort our COVID-19 patients into areas of the hospital where the L&D area is not. We also do temperature checks on all of our employees, including physicians, when they come into the hospital. And we also have universal masking in our high-risk areas, and L&D is one of those. So I think those three things are really going to help people feel more comfortable coming into our hospital.
And Lori Harding, how about Dignity Health?
Yeah, very similar to my colleagues. So we do cohort the COVID patients away. We have separated areas when you have a patient coming into the emergency department. Before they actually enter, they are screened for respiratory problems, and they're taken to a separate area of the hospital for treatment. So those non-COVID patients that come in, I think they can be assured that we are taking all precautions to make sure that they remain safe.
And Trish Rodriguez, let's talk about Kaiser. I know the Kaiser Permanente folks out there want to hear what you're doing.
Sure. Well, similar to my other colleagues, but we want our laboring moms to feel safe and confident when coming into the medical center. So we take precautions such as screening, cohorting, as my colleagues have done. We want this to be a joyous time in their life, and we're confident we can create the safety to do that.
All right. Thank you all so much for your time. We appreciate it very much. And we just again want to thank Lori Harding with Dignity Health, David Cheney with Sutter Medical Center and Sutter Health, Trish Rodriguez with Kaiser Permanente, and Dr. David Lebarski with UC Davis Health. We lost his shot, but some great information while we had him. So we appreciate your expertise really from all four of you. Thank you so much. This is important information for our community. And we want to point out that coming up in just 3 hours, NBC is answering more of your questions in a live special. The primetime special Coronavirus Pandemic airs at 10, so I guess that means it's coming up in 2 hours from now.
And then we will bring you the latest headlines, of course, on our KCRA3 News at 11. So it's good that we've had you here. It's good that we could talk with all of these experts as well.
And we also want to walk you through some of the resources that we have, starting with symptoms of the coronavirus. So we have a graphic that we can show you. And I think that you've heard some of this so far, but we want to make sure that you have this once again, that it causes a mild to moderate respiratory illness. You may experience a fever, a cough, shortness of breath, and this tends to be more severe among people with compromised immune systems. We can also tell you about some resources. And these are some of the places that you can look for information. You can find more information at cdc.gov/coronavirus. That's at the federal level, or here at the state level, covid19.ca.gov. And in addition to health information, they also have a lot of resources. So if you need to file for benefits and some of the financial help, the state website has all of that as well.
There's a lot of information out there right now, and we're so glad that you could be here with us for this KCRA3 live special, Coronavirus State of Care. Again, Edie and I will be joining you for our news at 10 over on My 58, and then we'll be back here at 11. Good night.
Good night.